The books tell you about 1 to 2 minutes in between you hyperoxygenate and hyperventilate. At least a minute. 1 to 2 minutes, okay, in between. All right. What if the patient say, stick that catheter down? We have some patients that tell you. You know, you meet the resistance, you stop, and you suction it. And they tell you, like, no, more.
You should calmly reassure the patient, I am a
Because they want that catheter to go down to in the left main stem or something like that. Or, you know, right main stem, well, you know, wherever they want it. They feel the secretion sitting somewhere, and they want you to get that out. It happens all the time. So you can try to go down and see what they can do. I mean, it depends on the patients. We got this guy, Mr. Kuiper. Have you ever you guys seen him in sections? Yeah, he will tell you. You know, if you stop suctioning him at the certain point, he said, more. You know, so you stick your catheter down there. You know.
You got a big old callus on his brain.
Yeah. So he'll be fussing at you if you don't do it. But it's not a normal procedure, okay? All right. How long you will be suctioning this patient? How many times? That's the next question.
Until you're clear of secretion.
How do you know?
Because when you go to rinse it out, you're gonna, well, you know, when you go down and you don't come up with anything that's clear or
That's a good one. If you can't get any more secretions, like a thick secretions, you may want to stop.
like when you rinse, you know, and you go back down. That's what I'm saying. When you rinse and you go back down and you're not getting anything back up in the tube, you know what about it.
Then you use that. A couple things, like if the patient goes bad, you stop. And if if don't have any more secretions, you stop.
They should have listened to breath sounds first.
Well, the thing is, yeah, you already listen to the patient breath sound, that's why you're suctioning anyway, right? But in between, you can't listen to the breath sound. Your hand is all full of mucus. How are you going to pick up your stethoscope? It's important.
Put your ear in the
No. You just actually, when you bag somebody, you kind of know. If they're sounding like that, you know there is some stuff down there. Okay? Okay. But when you bagging them nice and smooth, you know there is no more stuff down there, and you can't get any more through the catheter either. You stop suctioning. Sometimes you go down once and come out, everything is clear. Sometimes you can go down about 5 times, you still have stuff down there. Don't attempt to suction somebody 20 times because they have something down there. Because you'll suck all that oxygen out, now they're dead. So, I would say
yeah,
maximum.
I always like, what I do with my daughter is like if I go to suction, especially if she's sick, I go to suction her and then I'll put her back on the ventilator, or you can ambu bag a person for a few more minutes if you're going to have to go. Because if you see them kind of go down in their sats after you suction them, I always go back and put her back on the vent for a few minutes, or ambu bag for a few minutes, and then suction again.
Right.
If you have that kind of patient that kind of just, when you do it.
Do it twice? Okay. For the learning purpose, do you look at your hand out and see, did it tell you how many times you can suction the patient? I don't think you have that. It says, reassess the patient.
If second attempt, rinse catheter, sterile water, completed assessment, flush, sterile.
It doesn't.
Entire procedure.
Yeah, it doesn't know. It doesn't tell you how many times. Okay. But I would say about 2 or 3 times. That's it. Okay.
It does talk about the saline.
Yes. All right. All right. One more thing I'm going to talk about is if the patient has a lot of thick secretions, can you put some saline down there and bag the patient and suction?
Yeah.
Okay. Why do you put the saline down there?
Thins it out.
Thins it out is wrong.
Well, sometimes when you have
It's what's already
dry.
in the bottle. You're not introducing foreign.
Well, the thing
It
is,
irritates me.
saline, we used to use lots and lots of saline for suction. What happened is, we came to find out, we are actually causing pneumonia. Why? Because we put the saline down there, we don't even get that back when we suction. Like, if I put down 6 cc's of saline, I get 3 cc's out. If I suction like that about 10 times a day, how much saline that's gonna go in the lungs and standing there?
If my daughter's secretions are like dry, and I put saline down, sometimes it doesn't really come up because it's dry and it's like, you know, you put saline down, it kind of loosens it, moistens it, and it slides up.
Yeah. But one thing you have to do is, we stopped using a lot of saline in the hospital. We actually stopped providing them because they were putting down a lot of saline. Saline, only thing saline does is wash that secretion off. That's all it does. It does not thins the secretions. It does not break up the secretions. That's all myth. I mean, people think that way. It does not do any of those things. What it does is really, you know, washes it from the side of the airway. Okay, so if you have some secretions in the airway, dry it up. Only thing it does is washing it. When you suction, you get that in the catheter. Okay? What do you actually need to put it in the airway to break it up? Mucomist. Mucomist is the only medication that really does it. So
Plus,
if you have,
you would hope they were on a good unification system too.
yeah. So don't use a whole lot of saline.
No, you don't.
Okay? You have to, you can use it, but don't use it a lot. It's not gonna do a whole lot of stuff. You would think that it's really helping, but it's not really helping. Mucomist, you have to have an order by the doctor. You cannot go in a patient room and put mucomist in the, you know, in the airway and start suctioning somebody.
Yeah, well, you got on this thing, that's probably what I said this, because it says on there, on 20, on the paper suction, instill a small amount of saline down in paper 2, that may be used for secretions of too thick. So
Yeah.
it sounds like it's thinning
Well,
it, but,
thick means it does not break it up.
yeah.
What we mean is, if they have thick secretions, you can wash it
Mhm.
from that airway and you can normally suction it out. It's a big
That's why it
thing.
sounds like thin, because you
Yeah.
got thick and you're thinking, put it down, it's gonna be thin.
In the hospital settings, the ventilator-associated pneumonia VAP rate was like up here, 5 years ago. And nobody knew why these patients are getting pneumonia. All of a sudden, a study went out and they checked all the patients that used, you know, everybody using saline versus not using saline, and the number actually went down. The patients that not using the saline. So they came to find out the saline is actually causing the pneumonia. So that's why we cut down on the saline. I'm telling you, you usually use like 6 cc's of big saline bullet. We pour that down in the ET tube all the way, and such and such. Everybody did that. We all did. Now you can't even see a saline in the room. You have to look around. Like yesterday. Remember? Yeah. That doesn't mean you don't use it at all.